Yeah, I think we can make a start, Eleni.
Okay, um, so we're delighted to welcome two very distinguished speakers this afternoon, and we're starting with Dr. Konstantinos Linos, who is our first speaker, and he's going to give us a lecture on nevus, melanoma, or something else, superficial mesenchymal neoplasms with melanocytic differentiation. Konstantinos is originally from Athens, Greece, and he currently practices derm path and bone and soft tissue pathology at the Memorial Sloan Kettering Cancer Center. He has had clinical training in the UK and Australia and anatomic pathology training in the US, after which he pursued 3 fellowships on oncological surgical pathology at MSK, where he currently is, at bone and soft tissue with Sharon Weiss, and dermatopathology at Indiana University. Konstantinos, over to you.
Well, thank you very much for the kind invitation. Yeah, probably you don't know that, but I was a house officer in Underbrooks more than 20 years ago. So I did my share in the NHS. Um, so my talk is a talk that I have a passion about it because it's at the crossroad between the crossroad of what I do, dermatopathology and soft tissue pathology, and basically the target of this talk is to convince you that everything that has melanin production or has melanocytic differentiation, it doesn't mean necessarily is a nevus, is a melanoma or a melanocytoma, but it could be actually different lineage. It just happens that the genes have been hijacked and the tumor produces differentiated towards the melanocytic lineage. I have no financial disclosures. So we're going to talk about a few things today. We're going to talk about malignant melanotic nerve seed tumor, one of the prototype tumors for tumors with melanocytic mesenchymal tumors with melanocytic differentiation. We're going to talk about picomas. We're going to talk about clear cell sarcoma, and some relatively new entities such as CRTC TRIM11 cutaneous tumor, the so-called MITF pathway activated melanocytic tumors, MED15 ATF1 fused rearranged tumors, and the non-OTF3 cutaneous epithelial and spindle cell tumors, some new stuff that have been out there that there seems to probably are distinct entities, but we don't know a lot about them yet. So malignant melanotic nerve seed tumor, that's the latest, the new name for those of you who practice many years. The old name melanotic schwannoma is not recommended anymore. When we use it, I may use this name because it's easier, but there is a reason why we don't recommend this name anymore, and I will explain you why. Another acceptable terminology is malignant melanotic Schwannian tumor, but the term melanotic schwannoma or Psammomatous melanotic schwannoma is not recommended. So I'm just going to use malignant melanotic nerve seed tumor is a rare tumor of putative neural crest origin. And most often, you're going to see it in paraspinal nerve roots and the gastrointestinal tract. That is the most common clinical scenario you're going to encounter in your careers. But of course, it can happen in other locations as well, and skin included. And as you know, it has an association with stigmata of Cardiac complex. And you remember from medical school, Cardiac complex has skin pigmentary abnormalities. Patients come with cardiac myxomas, and sometimes that's very important to recognize it because the first presentation for a patient can be with a cardiac myxoma that can cause sudden cardiac death. So immediately patients with the diagnosed cardiac complex will get a cardiac ultrasound. And there is these patients also have endocrine tumors and endocrine hyperactivity, and they have germline mutations on PRKAR1A gene, the BRCA1A gene. So these tumors can be multifocal, and that can raise concern for malignancy. And about 8% of patients with Cardiac complex will develop malignant melanotic nerve seed tumor, where approximately half of patients who have malignant melanotic nerve seed tumor, these patients are associated with Cardiac complex. What is the cell of origin? It's unknown. People have looked at this, and the cells have a hybrid light microscopic and ultrastructural features of Schwann cells and and melanocytes. And the reason we don't recommend the term melanotic schwannoma anymore is because we can't predict how this tumor is going to behave. As a matter of fact, up to 44%, up to half of the cases will metastasize, including cases that they look completely histologically benign, banal, bland. So imagine you're a patient and you get diagnosed with a malignant melanotic nerve sheath tumor, or the old days melanotic schwannoma. You go, you have your appointment with your clinician, and the clinician tell you, I have no way to tell you. You flip the coin. I have no way to tell you if you're going to develop metastasis or not. We can't tell. So this is the reason why we don't recommend, because it's actually a lot of the cases metastasize. So this is a classic case of a malignant melanotic nerve sheath tumor. They're multinodular. They're generally circumscribed masses. A minority of cases may have at least partial encapsulation, but most of the time these tumors are encapsulated and they grow into the surrounding fibroadipose tissue. And the cells have this fascicular growth pattern. They look quite bland. They may have pseudonuclear inclusions. We're going to see some pictures of high power, and you see a lot of melanin granules by H&E. So if you see that, and in a classic location, paraspinal, sacral, then your first thought should be this is probably a malignant melanotic nerve sheath tumor, and they have an inconspicuous vasculature. So this is a high power. You see they're quite bland cytologically. They have fine chromatin patterns, pseudonuclear inclusions, and then they have a lot of melanin. But you can see different cytological patterns, and actually you can have cells that they look quite epithelioid. And if I show you this picture in isolation, I tell you this is a case of melanoma, you will probably believe me, but this is actually our epithelioid cytological features in a case of malignant melanotic nerve sheath tumor. So if you put a lot of sections, so one of the easiest thing to do is actually go back to the bucket and put more sections. You're going to see more classic cytologic and architectural features of malignant melanotic nerve sheath tumor, meaning this fascicular growth pattern and the kind of spindle to ovoid cells. They can have, as I said, prominent pseudo-inclusions, a lot of melanin. They can have degenerative nuclear atypia, and they can have actually a lot of areas that have a lot of clear cytoplasm, kind of resemble a lipoblastic tumor. And they can have zero, a few, or a lot psammomatous bodies. And contrary to what we have been taught in the medical school, the presence of psammoma bodies or not, it is not associated with, cannot predict if this tumor is associated with cardiac complex patient. It is irrelevant. It's just within the spectrum, and you can see that in patients who have germline mutations of the genes, hence cardiac complex patients or sporadic tumor. It doesn't make any difference. Different patterns, you can see cytologic architectural patterns. You can have a lot of myxoid changes. You can have what we call a small cell pattern, or you can have what we call a ripple pattern, a ribbon like pattern where you see that, the things that you see in neuroendocrine neoplasms. But again, if you put quite a few sections, it is almost certain that you're going to see classic features of malignant melanotic nerve sheath tumor, and in context, in the appropriate clinical pathologic context, then the diagnosis should be quite straightforward. They stain like melanomas. They stain like S100. They're going to stain for SOX10. They stain for melanine. What you expect in a melanocytic tumor. This is a big study by my very good friend and co-resident, Jorge Torres Mora, who is practicing at Mayo Clinic in Rochester, Minnesota. And they studied and they proposed to change the name, and that's what happened in the subsequent WHO classification. But I want to draw your attention to a couple of things here that are actually important. I don't do anymore just S100. If I want to define if this is melanocytic lesion or in general, I always do S100 SOX10. I don't do it by itself. And a minority of malignant melanotic nerve sheath tumor, they're S100 negative. So if your S100 is the only stain that is your screening marker, then that can be problematic in the minority of cases that this happens to be negative. And the other thing is GFAP is always negative, and schwannomas are up 50% positive. So that is another clue that this is not your regular schwannoma, the old name melanotic schwannoma. But I think this is important that a minority of the cases can be S100 negative, but they're always SOX10 positive. I told you that you can have germline mutations on the PRKAR1A gene or sporadic. The sporadic tumors will have this mutation in the majority of the cases, and then you can have immunohistochemistry. It's a little bit difficult to validate this immuno, but anyway, if there is the mutation, you expect to have loss of expression. It doesn't correlate 100% with the molecular background, but it works quite reliably. So if you have loss, then that is a surrogate marker that you have a deletion or anyway a mutation that affects the protein expression. But is that specific? We'll talk about a little bit later. Now, people looked at this and can we predict? That's very important, right? We have made good progress diagnosing this tumor reliably. And then we realized that we cannot tell 44% metastasize. So we have the important clinical question is, can we predict? So people have looked at this, and one thing that only was statistically significant is if this tumor has more than one mitosis per 10 high power flow. So if you see more than one mitosis, then you start worry. But if you don't see any mitosis, that doesn't mean anything, because approximately half of the cases in this big study the half of the cases that actually had a bad outcome, they had zero mitosis. So essentially, even if you don't see mitosis, we're square zero, we cannot predict. But it's useful if you're differentiated with melanoma. If you search and you find one mitosis, two mitosis, that is pretty unusual for a melanoma of the size that you're going to have with malignant melanotic nerve sheath tumor. And this is a clue that you actually may be dealing with something else other than melanoma. Does malignant melanotic nerve sheath tumor happen in the skin? Yes, it does. It's very rare, but it's well documented. It's a very nice study from Philip Lebois and University of San Francisco that quite a few years now that they studied a case that's they had a case and then they were back in the literature and they found that there were some well-documented cases of superficial malignant melanotic nerve sheath tumor. So what about the cutaneous, the superficial, the rare ones? They tend to arise in the trunk. They have largely equal gender distribution. And the same thing with malignant melanotic nerve sheath tumor on the deeper soft tissue. There also can be associated, up to half of the cases associated with carnate complex. So when we see that in the skin, what is our differential? Of course, your big differential is pigmented epithelioid melanoma that we talked. That is your big differential. And but the main differential, I think, morphologically, which potentially can be quite challenging in a subset of cases, is the pigmented epithelioid melanocytoma, right? The melanocytomas. Melanotic neurofibroma is in the differential, but they will have a little bit different cytology, and they tend to be a CD34 positive, where the malignant melanotic nerve sheath tumor is CD34 negative. And the cytology is a little bit different. It's more spindle, and then variants of balloon nevi will be your differential and conceivably pigmented dermatofibrosarcoma protuberans. Now, if you see sammomatous bodies, that doesn't mean it's a melanotic malignant melanotic nerve sheath tumor, because sammomatous bodies it's not common, but they have been documented in melanomas or in nevus. So that's not going to tell you anything. So can you tell reliably malignant melanotic nerve sheath tumor with melanoma? Well, the reality is, there are some tricks, but the reality is there are no absolute individual clinical pathologic features that are completely specific. And you have to put everything in context. I always teach to my trainees that, the pathologist is not sitting in a room and just see slides. It has a holistic view. You have to look at the chart. You have to get the clinical information, then you have to get the morphology, then you have to get the protein expression data, immunohistochemistry, molecular data, put everything together and make your final determination. So if the tumor is paravertebral, it have a lot of melanin, you see some bodies, and most importantly, if you see striking nuclear pleomorphism, but you don't see any mitosis, that is a clue that you may be dealing with something else other than melanoma. It's the same rule applies with sarcomas. If you see something that looks horrible, mesenchymal, and you look and you look and you look and you don't find a single mitosis, well, maybe it's not your terrible high-grade sarcoma. Maybe it's something else. And that is very common in other mesenchymal tumors. For example, I'll give you an example, superficial pleomorphic CD34 fibroblastic tumor, right? If you're not familiar, it looks terrible. You want to call it high-grade sarcoma, but you can't find a single mitosis. Kind of the same principle applies here as well. And of course, detailed clinical history, I cannot emphasize that enough. And careful dermatologic examination. People have looked at gene expression profiling data to see, is it a distinct entity, is it different? And it clearly segregates from melanoma. Melanoma here is the red, and the melanotic malignant melanotic nerve sheath tumor is the blue, and the classic schwannoma is the green. And there's clearly separated on the gene expression analysis, which is actually further core evidence that this is a distinct entity. And people have actually done epigenomics and the methylation profiling, etc. And the malignant melanotic nerve sheath tumor, they have a different epigenomic signature comparing to conventional schwannomas or melanocytomas or melanoma. So it is a distinct entity. Now, mutations on PRKAR1A gene, germline or sporadic here, they're not specific for malignant melanotic nerve sheath tumor. So if you do the immuno and it's lost, it doesn't give you the answer necessarily. It's another data point with the other data that you have to take into account, because we know that this is common in the so-called pigmented epithelial melanocytoma, which in my opinion is not a distinct entity, it's a pattern. And what happens is you have a driver, you have a BRAF mutation, you have a RET fusion, you have a GNAQ mutation, etc., etc. This is your driver, and then which gives you a distinct morphology, some of them, but then you get a second hit, which is on the PRKAR1A gene, and then the morphology changes and gets the morphology of PEM. So that's the concept. So, but the important here in relation to malignant melanotic nerve sheath tumor is that it's not specific to this tumor. So how can you separate it? Because the pigmented epithelial melanocytoma is rare, but is more common in the skin than the malignant melanotic nerve sheath tumor on the skin. I think if you have a background nevus, let's say you have a BRAF nevus, and then you have a second hit, and then you get this thing that, the old name, animal type melanoma, then it's easy because you have a background nevus, so it's a nevus that had a progression to something else. But you can do the cells, the cytology, they look a little bit different. They look more epithelioid, more what we call fried egg. They don't have this kind of a spindle ovoid configuration, pseudonuclear inclusions that you see in malignant melanotic nerve sheath tumor. And usually the malignant melanotic nerve sheath tumor has quite a bit of melanin comparing to the PEM. But it's hard. And these ones, they have, as I told you, mutations in the PRKAR1A gene. So if you do the stain, you're going to see loss as well. And it's sometimes difficult stain, but you see the internal positive control, the smooth muscle here. And actually, if you see the cells, they have no staining, so that means they have loss. But this is a pigmented epithelial melanocytoma, which would be your differential. And of course, the PRK, the mutations in the protein kinase A regulatory subunit, they're not specific to PM or malignant melanotic nerve sheath tumor because they're well-documented melanomas that they have this mutation. And this is quite a nice studies from the UCSF group a few years ago of PRKAR1A inactivated melanomas. So it's not that straightforward. So this should be in your differential. but you have to have in your mind a pigmented melanotic nerve sheath tumor as well. So what about a PRAME? Well, you use PRAME a lot in certain scenarios. Sometimes it's very helpful, many times it's useless. So people have looked at this, and actually, in many cases, in almost all cases, PRAME is negative. So if your differential is, could this be melanoma or not, and you get a tumor that is PRAME positive diffusely or strongly, then it's probably not a pigmented a melanotic nerve sheath tumor, because melanotic nerve tumors are negative with the data we have so far. So people have done a few stains, so it's negative. So if it's negative, it's not going to tell you anything, because 20% of melanomas are negative, but it's diffusely or strongly positive. Then it gets you away from your thought of could this be a malignant melanotic nerve sheath tumor. But things are not that straightforward. It's never straightforward, but it's rare. But they are, for example, this is a well-documented case, I believe, very convincing, very good paper, that of a malignant melanotic nerve sheath tumor, which had the PRKAR1A, but also had GNAQ mutation as well. So it's not always clean, but this is extremely rare. I just want to put there because weird things can happen, and actually people did the genetics and under supervised UMAP dimension reduction analysis, and they actually didn't classify close to schwannomas with the Heidelberg classifier. So this can happen, but this is very rare. So this is the one of the prototype tumors of mesenchymal tumors with melanocytic differentiation, and the so-called malignant melanotic nerve sheath tumor. Let's move now to a different tumor, which is you're going to see it more commonly in the skin. It's rare, but you're going to see it in the skin if you practice 10, 20, 30 years. Picomas. So what is picoma? So mesenchymal tumor, it's a mesenchymal tumor that's composed of the so-called perivascular epithelial cell, the PEC cell, which is a distinctive neoplastic cell that it has no known normal counterpart, and it has a unique immunoreactivity. So PEC cell has immunoreactivity for both melanocytic and smooth muscle markers. And there are very well documented series of primary cutaneous picoma many years ago from the Boston group and other colleagues that they have documented that. And this is your classic case of picoma. And actually, if you see a couple of them, you'll think about it. Sharon Weiss always was telling me it has this fine granular quality, the cytoplasm. So once you see these, it kind of resembles kind of histiocytes, but not quite, and has this quite very fine granular quality on the cytoplasm. Think about picoma. And this is what I mean. They look quite bland if they're not malignant. We'll talk about this. Inconspicuous nucleoli, and they have this kind of trabecular, they have this a lot of delicate, a network of delicate capillaries with this, as I said, this clear granular cytoplasm, and the mitosis are low. This is another tumor. You see that can be quite infiltrative in between collagen bundles, and you see that delicate, this very distinct granular cytoplasmic quality. Think about picoma. And then if you do the stains, they're going to have a dual expression of myomarkers and melanocytic markers. So this tumor expresses HMB45, which is the most sensitive marker, and desmin, with a caveat. We'll talk about this. So a distinct immunophenotype, HMB45, if you're going to do one, is the most sensitive, but it can stain less less sensitive for MITF or melan-A, and then smooth muscle markers. But the primary cutaneous picomas are less likely to demonstrate myomarkers. So it's not uncommon to get a consult where it's a picoma, but you do myomarkers that are negative. They're only a positive for HMB45, maybe melan-A, and of course then it takes you to a different route. Or could this be a balloon cell nevus, a balloon cell melanoma, or whatever? So you have to be aware that myomarkers, actually a lot of cases that don't stain or that's very focal, expression, and that is a pitfall. But again, the morphology is very characteristic. So the University of San Francisco group have looked at this, and you see your SMA very focal, desmin negative in many cases, calponi negative in many cases. Now, CD68, I don't use this stain. CD68 is not a lineage-specific stain. It's not a histiocytic stain per se. It's actually what it does, it just stains lysosomes. So every tumor that has a lot of lysosomes will stain for CD68. So if you want to use one marker, I prefer, it's a very good marker, the PU1. It's a nuclear marker. It's great because if tumors will have a lot of histiocytes, you can actually see very clearly what are the histiocytes and then the surrounding tumor cells, or you can use CD163. It's more difficult because it's cytoplasmic, but CD68, I mean, you can use it, but you have to be aware of the pitfall because it just stains lysosomes. Now, you put CD68 in a granular cell tumor, it's all brown because it just stains lysosomes. So if you're going to do one panel for picomas, that's a good panel. We'll cover a lot of your differential, S100, SOX10. I always do it together, as I said, melanase, MB45, SMA, and desmin, and that will cover a lot of things that you have in your differential. Now, a distinct subset of picomas that can look very melanotic. You can see a lot of melanin. That hasn't been reported in the skin yet. It has been reported in other anatomic location, the so-called melanotic picoma. And these melanotic picomas, they have, the great majority of them, if not all of them, they have TFE3 fusions. So you can see here they can be very, very melanotic. And you can see here, but if you search enough, you're going to see that characteristic granular quality in the cytoplasm. But other tumors can look very clear with melanin, kind of resemble a melanotic renal cell tumor, renal cell carcinoma. But this obviously going to be keratin negative, PAX8 negative, and there are areas that look more characteristic. And this tumor, they tend to actually to be negative for biomarkers. So you do your desmin, they're probably more likely to be negative, but they're positive for biomarkers. And then the TFE3, it's a finicky antibody. It works well as a surrogate marker only if the strong and diffuse expression. PRAME in picomas, people have looked at this, and PRAME can be 0 or it can be 4 plus. It's not specific, so PRAME is not going to help you here. PRAME can be, in a lot of cases, even more than half of the case can be diffuse and strongly positive, or it can be negative. So it's not a useful stain if your differential is with melanoma, something else. Now, specific subtype of picoma that you're going to see on the skin, it's actually important to know the so-called fibroma-like picoma. They look like fibers, non-specific, can't put it in name, but they're more cellular. They're more cellular than a scar. Doesn't really resemble anything else. So think about fibroma-like picoma, and then if you do the HMB45 or the biomarkers are going to be positive. And the important thing to know this subtype is because they're associated with tuberous sclerosis syndrome. So if you have a patient that has known tuberous sclerosis and then have a superficial lesion that looks kind of fibrous, more cellular scar or something like that, think about fibroma-like picoma. And the other way around, if you diagnose a case as a fibroma-like picoma, then you have to put a note because you have to check clinically this patient if he has tuberous sclerosis stigmata. What are the genetics of picomas? We know that about half of the cases have TSC2 mutations, and then the other half have translocations. Many of them as TFE3, not just the melanotic picomas, but other picomas as well, which they have kind of more characteristic morphologic features. But then there are other molecular events that can happen in picoma. And that's very important because if they have TSC2 mutation, for example, then mTOR inhibitors can potentially work clinically in picomas that they behave more aggressively. What is a differential? You see that white, kind of whitish, clearish cytoplasm and stains for HMB45, melanae, balloon cell nevus. Clear cell melanoma, that would be your differential. Clear cell sarcoma would not really be your differential. That is, it's not really clear. Clear cell sarcoma is more eosinophilic, but and it's diffusely positive for S100 and SOX10, where picomas are negative for SOX10, and S100 is very rare, and usually they are focal for S100. And of course, metastatic clear cell carcinoma, you have to think about that, but this would be positive for keratins and PAX8, and usually negative for melanocytic markers, with the exception of melanotic XP11 translocation renal cell carcinoma. And the other big differential, we're going to talk a little bit about it, is the so-called MIDF pathway activated melanocytic tumors. Other malignant picomas, yes, they are. People have done big studies in the soft tissue and the GYN world, and they have come with criteria. So if it's less than 5 centimeter, if it's not infiltrative, doesn't have high nuclear atypia, you cannot find any mitosis, then behave in an indolent fashion, but it has 2 or more worrisome features, then they can behave in aggressively. Aggressively, we'll call them malignant. And if they have one of the 2, uncertain malignant potential, but usually these, they are behaving in an indolent fashion. They're more on the benign spectrum. And sometimes are very difficult because to recognize, because they can look like undifferentiated pleomorphic sarcoma. This is a case of molecularly confirmed malignant picoma, but I think, if you don't do the molecular, if you don't do your HMB45, you don't think about it, then you're going to do your basic stains. They're going to be negative. You say there is no line of differentiation, then it's consistent with a pleomorphic dermal sarcoma or an undifferentiated pleomorphic sarcoma. But this actually was a case that had some HMB45, some H called Desmond, and it had a TSC2 homozygous deletion, hence a malignant picoma. And interestingly, it had a diffuse, a strong positive for TFP3, but had no TFP3 alteration. So it's not a perfect surrogate for underlying TFP3 alterations. And this is a summary of, maybe there are a couple of more, but there are a handful of cases of truly malignant picomas in the skin. It's just something you have to have it in your mind. So what is the differential? The differential is what is in the latest WHO MITF pathway activated melanocytic tumors. Why this is in the melanocytic chapter it's a mystery, and actually I don't think it's going to stay there for long. And I'll explain you why. Because we don't believe that these are truly melanocytic tumors. Actually, we believe it's something else. We're going to talk about it. But anyway, for now, it's under the melanocytic, but it may actually change in the next WHO classification. One of this tumor is the tumor that shows melanocytic differentiation, has actin MITF translocation. And you can see here a tumor that kind of resembles cytologically picoma. Trabecular growth pattern, very infiltrative in between collagen bundles, and this tumor had HMB45, S100, MITF. What doesn't fit for picoma is in this paper that this tumor showed diffuse S100 expression, where picomas most of the times are negative, or they may show focal or multifocal at most. But there were cases that were negative or focal, or a little bit of S100, but 3 cases in their study were positive, and they all had MITF fusions. And this is another example that has the cells a little bit more prominent nucleoli, this cytoplasm, clear cytoplasm, and this was diffusely strongly positive for MITF, and this tumor was negative for S100. For the most part, they have behaved in an indolent fashion, but there was recently a case of actin MITF rearranged tumor with melanocytic differentiation, who rapidly enlarged. You went from this to this. That's pretty impressive. And then this another paper we just published this year of MITF fusion with ACDG1, and again you see kind of resembles a picoma, and I'll tell you why I say that in a minute. Infiltrating in between collagen bundles. So actin MITF F1, what happens is you get the rearrangement, and you have activation of the MITF pathway, because the MITF retains its transactivation and DNA binding domains. Hence, you have a activation of the MITF pathway, probably from the promoter of the ACDG1 gene here. So what do we know about these tumors? There are 15 cases that have been published so far. They have a striking female predilection. 11 out of 15 they were women. 12 tumors arose in the lower extremities, and there are a couple of them in different anatomic locations. And in these tumors, always MITF was diffusely positive. HMB45 was focal, diffuse in many cases, but there were some cases that it was negative or focal. So that was not consistent. S100 was negative in 7 cases, 8 cases. It was positive in 6 cases, so there can be cases that are positive or negative, and it was focal to diffuse, and SOX10 was negative in all cases. And melanase and tyrosinase was negative to positive, so the consistent finding was MITF. So this is another stain that you have to put in your armamentarium when you are in this kind of differential. So HMB45, melanase, they were just could be positive, diffusely focal. The consistent finding was MITF was diffusely positive, and SOX10 was always negative. This is the 2 consistent findings. And then cathepsin K was negative. We use that for picomas, but the GPNMB, a new marker that we use for picomas, it was positive in the 2 out of 2 tested cases. They had an indolent course. For the case that we have clinical follow-up, there were 5 cases, 4 were disease-free, but 1 had a local recurrence. And then this recent report that it has was a large ulcerated mass, but this tumor showed cytologic atypia and some mitosis, but follow-up was unavailable. Now, the question that arises, and people are looking this to it as we speak. Actually, I reviewed a recent paper that will come to Vircho's, will get published to Vircho's archives soon. Is, it resembles picoma, kind of stains like picoma. If you don't take into account a few cases that were diffuse S100 positive, that doesn't fit. Is it actually a primary cutaneous picoma? Does this have actin MITF fusion, or is something else? So what do we know about primary cutaneous picomas? There are 78 cases reported in the English literature. 12 have been designated as malignant. And 8.5% of these that were positive, reported as positive for S100. 87% that were positive for HMB45, not all of them, but 87. MITF was positive in 96% of the cases. And SMA was positive 37% because I told you the primary cutaneous picomas are less likely to show biomarkers. And Desmond was 31% of the cases. So we think it's an open question, but we think, and I think too, and many of us, is that probably the actin MITF is actually probably primary cutaneous picoma with actin MITF. And actually there is at least a case of deep picomas that they have the same fusion in the literature. So they are probably picomas rather than a distinct entity. And they are MITF pathway activated because picomas have MITF pathway activation. The other tumor is the MITF CRAM. It's another novel entity. This is one of the first tumors that was described you can see here the clear, very, very infiltrative. Some of the areas that look a little bit more atypical with more eosinophilic rather than a clear cytoplasm and kind of a nucleomegaly. So this was one of the first that had MITF CRAM fusion, and it was diffusely positive for SOX10 and S100, and also MITF and melanase. And this was a second case that was reported with the same fusion. This was actually a pediatric case that it looked more atypical. It was less clear. That's what happened if you describe tumors with by morphology. Then it made that when you realize that the morphologic spectrum is wider than you thought initially, then the name becomes inadequate. But anyway, it cannot be just clear because it can be more eosinophilic, as you see here, some perineural entrapment. This was a kid, I believe, and this was again, you see the more atypia that you have, and it was diffusely positive for SOX10 and HMB45. And this this mass was re-excised, and as far as I know, didn't have a recurrence. And then this was a third case, again in a child with a lot of mitosis, quite a bit of atypia here. It's not clear, but this have exactly the same fusion, the MITF-CREM fusion. So how does it work? It works different from the actin MITF because in this fusion, the MITF activation domains, they're not retained. So it kind of works similar to what we see in the clear cell sarcoma, the AWSR1, ATF1. So what happens, we have probably activation of the CREM pathway of the CREM by the MITF promoter. And what happens is probably activates the non-translocated allele, and then you get pathway activation and melanin production and melanocytic differentiation. What do we know about this tumor? 3 cases have been reported. All cases were diffusely positive for SOX10 and S100, diffusely positive for MITF in 2 out of 2, focally positive for HMB45. Melanate was variable. So this belongs to the MITF pathway activated melanocytic tumors for now. There are 3 cases. Most likely there will be more cases. Just have something to be aware. So don't call it melanoma, especially if you see that on a child. Think about a fusion-driven tumor, and I think you should have MITF. When you encounter this kind of differential, I think we should use MITF stain to see if the MITF pathway is activated, because that would get us to the different box in terms of differential. The other tumor, the prototype, is the clear cell sarcoma. So clear cell sarcoma is the prototype. It was actually described by Franz Enziger, who was the mentor of my mentor, was the mentor of Sarah Weiss. Sarah Weiss was my mentor back in the 60s. And actually, it's interesting because Franz Enziger, he saw the melanin granules, but he dismissed them. He didn't clue him that this could be a clue for the lineage of this tumor, for the differentiation of this tumor. He thought it was, he dismissed them. But then in the 80s, they did electron microscopy and they found out there are melanosomes. So they went back and they named it malignant melanoma of soft tissue parts. And then went back again. They realized, oh, this is not your classic melanoma. It's clear cell sarcoma. We just it has melanocytic differentiation. So when you see it on the skin, I mean, usually it's in the young to middle-aged adults, in the foot, ankle, etc. So, but when you see it on the skin, the first thing you should have in mind is this the tip of the iceberg of a deeper tumor that goes up into the surface. You have to exclude that. You have to do imaging, etc. But primary cutaneous dermal, clear cell sarcomas are very well described. And of course, your differential would be with melanoma or Spitz melanocytoma and things like that. One clue that this is not melanoma, and we always use that, it's the clue with H&E. If you see something that looks very uniform, sarcomas are divided in 2 broad categories. The fusion-driven sarcomas, that there are about 30%, and the pleomorphic ones. The fusion-driven sarcomas, if you look at the genome, it's very quiet. You don't see any copy number aberrations. The fusion is enough to give the advantages of clonal expansion according to the Darwin's laws, and to give you a clonal process and a tumor. So you only see that fusion in the appropriate microenvironment, the appropriate stem cell, etc., in the appropriate cell of origin. The pleomorphic ones, if you see the genome, it's all over the place. You have amplification, some gains of oncogenes, you have losses of tumor suppressor genes. They're all over the place, and it looks at the microscope pretty pleomorphic for the most part. So if you see something you want to call melanoma, it looks very, very monotonous. And it has melanocytic differentiation, but it looks very monotonous. You should pause and you should think, is this a fusion-driven tumor with melanocytic differentiation? Because even the Spitz melanomas, they don't look uniform. Because the Spitz melanomas, you have the drive, the fusion is the driver, and then you have additional hits and then you get a Spitz melanoma, which is very rare, by the way. But in fusion-driven sarcomas, you don't have, this model is not applicable. You have the fusion, and that fusion gives you the sarcoma from the get-go. All right, so this looks very uniform here. And you have the spindle cells, you may have prominent nucleoli, cherry red nucleoli, you see in melanomas, you may have what we call the Rithel-like multinuclear neoplastic cells. These are neoplastic cells with a lot of nuclei, and they have this fascicular growth pattern, and you may have fibrous bands in between, and it stains for melanocytic markers. Again, this tumor, you see that, if you want to call this melanoma, that's kind of weird because it looks so uniform. A melanoma of that size may actually look a little bit different, I think. Of course, it can happen. Anything can happen. The protein manifestation of melanomas are well known, but you just have to have that thoughts in your mind. And then you can see here the wreath-like multinuclear cells. But if you do stains, they're going to stain for SOX10, S100, melanate, whatever you expect in a melanocytic tumor. One other pitfall is they may actually colonize the dermal-epidermal junction. What do we do? The first thing we do if we have a tumor that it has melanocytic differentiation, we just go at the dermal-epidermal junction to see if there is a melanoma in situ, for example. So this tumor, many tumors can colonize the dermal-epidermal junction and resemble a primary tumor. This is an awful case that it was diagnosed as Spitz nevus many years ago, and then it came to our institution. And actually, Klaus Blusom published that. It was a very, very good case at that time. It came to our institution. Why did it come to our institution? Because it was misdiagnosed as Spitz nevus. It was never re-excised, and then it got a massive metastasis to the lymph node. So this actually, after appropriate workup, it was a clear cell sarcoma with colonization at the dermal epidermal junction. And this is well known. And believe it or not, this is not a primary cutaneous clear cell sarcoma with colonization of the dermal-epidermal junction. This is a metastasis of cutaneous clear cell sarcoma with epidermal tropism, the same way that melanoma can do. Pretty remarkable. So you have to have that on your mind. And you always have this in your differential. And how it's a very easy way to distinguish. Because a clear cell sarcoma, we know the molecular signature. They have EWSR1 fusions, EWSR1, ATF1, the most common, EWSR1 CREB, less common, CREM, very rare. Of course, these are promiscuous fusions. You can see in other tumors as well, but in this morphological and immunohistochemical context, that's very specific, quite specific. And melanomas don't have EWSR1 translocation. So that's a very easy way. You can do a FISH for EWSR1 and done with this. And another clue is to do PRAME. So all clear cell sarcomas are PRAME negative, and I will explain in a minute why. But melanomas, 80%, 60, 70, 80%, they're PRAME diffusely strongly PRAME positive. So if you have a tumor that is diffusely strongly PRAME positive, it is not a clear cell sarcoma. It is melanoma or something else. If it's PRAME negative, it's not helpful because melanomas can be negative. And why? And people have looked at this. You see here, PRAME are negative in all cases of clear cell sarcoma. And why? This is a busy slide, but I want to bring your attention to here. And it's very nice how the basic science data, after some time, become so helpful in our clinical practice. Because we know now, almost a quarter of a century, from the beginning of our century, that PRAME gene, it is one of the most downregulated genes in clear cell sarcoma. So that's why you get no signal with PRAME in immunohistochemistry, because the gene is so downregulated. So then that was well known, and we found a way to apply that in our daily clinical practice. So PRAME diffusely positive, that's the helpful. It is not clear cell sarcoma. And actually, I was the honor to chair the soft tissue subgroup in the American Society of Dermatopathology, where we come. There's an app in iPhone where we come with certain clinical scenarios, and when it's appropriate to use one test or the other in different clinical scenarios, melanocytic, hematolymphoid, etc., etc. And we did that for DFSP and clear cell sarcoma quite a few years ago, and we update that every 3-4 years. We are in the process of updating these. And there's actually an app of the American Society of Dermatopathology, where you can download and you can play with it with different clinical scenarios and different entities. We talked about the melanoma extensively, perivascular picoma, but this will not be diffusely positive for SOX10 and S100, especially SOX10, that is not. And of course, your classic differential is with cellular blue nevus, and the other big differential is with the CRTC TRIM11. So this is your classic differential with blue nevus. Here, this is a blue nevus with a cellular blue nevus with a dumbbell-shaped silhouette, but the cells, they're not that atypical. They're kind of more bland. They don't have prominent net nucleoli. They have fine chromatin pattern. You can see that they're less atypical, but of course you can have melanomas arising in a blue nevus. But these melanomas, they look more pleomorphic, right? It's not the fusion-driven model of sarcomas that look pleomorphic because you have the GNA11, GNAQ mutation as your driver, and then you have additional hits that gives you the progression to melanoma. And of course, the big clue is if you have background sclerosing nevus, blue nevus, or cellular blue nevus, then that is easy because that would give you the clue that this is no clear cell sarcoma. So this is the big differential. The CRTC TRIM11 tumor was described with the name of melanocytoma, which is not, we don't use that anymore. I'll explain you why. When you use the term melanocytoma, you don't call it nevus, but you don't call it melanoma. But what you imply is about biologic behavior. You imply an indolent biologic behavior. Melanocytomas, they don't kill the patient. They may go to the lymph nodes, but that's about it. They don't cause death. So that was very preliminary data, and this turned out to be wrong. So we don't think it's melanocytoma anymore, but resembles clear cell sarcoma, right? It has this spindle cells. If you didn't have that, you'd be very prompt to call this clear cell sarcoma. But it has this recurrent translocation, CRTC1 TRIM11 translocation, and there is an immuno, a TRIM11 immuno that works pretty well for this tumor. And this is the big study coming out from Boston. These cells that can look spindle, but they may have epithelioid features. They can look with quite monomorphous, but they can have some atypical features as well. Many of the tumors have necrosis. And one clue is, and I think I have another slide to show you, they have a very well circumscribed silhouette. They're never infiltrated. So that's something to keep in mind. I don't know how specific it is, but it may actually be helpful. All of the tumors, they have very well circumscribed silhouettes. It's a well-recognized entity now. It is under the soft tissue, this one. And it's called CRTC1 TRIM11 cutaneous tumor with partial melanocytic differentiation. And this is what I meant. You know, see, the silhouette is always very well circumscribed. That can actually clue you in if you have something that has it's spindle, it resembles clear cell sarcoma, has melanocytic differentiation, you're not sure, it looks very uniform, it could be fusion-driven. Just have that in your mind. All cases are SOX10 positive. If you do S100 only, half of them are negative, so that will confuse you. Melanase is in the minority of cases positive. TRIM11 is not very widely available, but it's positive in most of them. And for reasons we don't know, because there's overexpression of NTRK, but there's no NTRK amplification, there's no NTRK fusion or anything like that. We don't know why this is happening. It could be helpful, but as an indirect, soft data point. But they can behave aggressively. I'll show you the data in a moment. They can go to the lymph nodes, or even they can go to they can give distant metastasis. This is a tumor that metastasizes to the lymph node, bulky metastasis to the lymph node, and this is TRIM11. You can see stains nicely the nuclear, but doesn't stain nuclear the background lymph node. This is a tumor that metastasizes to the lymph node and subsequent to the lung. So they can show aggressive behavior. But not only in adults, and this is an extraordinary case that I was asked to review as a reviewer. It was a great paper by Pedram. It was a child And there was another case of CRTC TRIM11 who had pseudoepitheliomatous hyperplasia and had involvement of the dermoepidermal junction. A 9-year-old, something like that, a young kid. Great, take it out. And then after 9 months, I was asked to do another review because they have a addendum on this case because that kid gave a massive metastasis to the lymph node happened. This is the metastasis, look exactly the same like the primary. So this was a metastatic, and then it gave lung metastasis in a pediatric patient, and you couldn't predict. So what do we know? There are 81 reported cases so far. 56 cases have adequate follow-up. 14 cases of the cases with adequate follow-up develop metastasis. So it's no melanocytoma whatsoever. It's a malignant tumor. 25% develop metastasis of the cases with clinical follow-up. Of course, this may be, may have there's bias there. They can metastasize quite late sometimes, etc. But this is the data that we have so far. All cases are SOX10 and MITF positive, so you have to have that, not just S100. S100 can actually be negative or focal in half of the cases. Melanate can be, it's uncommon. So if you think it could be a CRTC TRIM11 and you have a strong melanate, it doesn't exclude it, but makes it less likely. Most of the time it's negative or focal, multifocal. So that could be another clue. And PRAME is negative in the majority of cases. So they look the same. How can we predict? That is the major question now, right? We're pretty good. We have the molecular technology to diagnose this if we think about it. But the next step in our research is, can I predict which patients are which patients are going to behave better or not? So this just came out. And actually, Dr. Jeremia is here as a co-author as well, which we actually made some work to see with new cases and then a meta-analysis of the cases that have been published so far and put everything together. How can we predict? Can we predict, and how can we spare some patients from aggressive intervention or be more aggressive in patients that have a higher risk? And what we noticed is that ulceration was statistically significant. Mitotic index was statistically significant. The tumor size was statistically significant. And then important, it's the TERT promoter mutation was statistically significant. So what happens? So the patients that are lower risk, and perhaps we could just avoid doing send a node or aggressive intervention and do a wide re-excision and watch them, is patients that have small tumors, less than 1.2 centimeters. They have less than 7 mitosis, and they have no promoter mutation. The data so far show that these patients may not need a send a node, and we may actually watch them carefully. Now, if you have one of these, then you have to be more aggressive. And importantly, if you have a tumor, that's why you need the molecular here. If you have a tumor that is small, that's less than 7 mitosis, but has TERT promoter mutation, there was one case that actually metastasized. So the TERT promoter is important. So that will make you, that it's the point that you have to decide if you have a small tumor that otherwise looks like low risk, small tumor, not many mitosis, it's the TERT promoter mutation. That is important to know. And I think I have 4 or 5 minutes, so I'll do the MED15 and stop. The MED15 ATF1 is not in the WHO yet. It may be. It's a novel cutaneous tumor with melanocytic differentiation. It has only been described in pediatric patients, and it actually can be quite aggressive. This was one of the case, epithelioid cells, a bit of spindle, quite atypical, but this had an indolent behavior. This actually had involvement of the epidermis. And then this tumor that actually behaved aggressively had subepidermal necrosis, had quite a few mitosis, prominent nucleoli. This actually gave metastasis. And the case that had indolent behavior was S100 positive, and it was low Ki67, where the case that behaved aggressively, they had a quite high Ki67. So what do we know about this? It's only 6 cases reported so far, but they have a recurrent translocation. They're all diffusely positive for SOX10 for S100. They were variable, sorry, for SOX10, that's a typo. There are variable staining for MITF, S100, melanine. The usual SOX10 is shows diffusely strong positivity, and PRAME was negative in 3 cases reported. And they can behave aggressively, so that's important. 3 cases actually gave distant metastasis, and 2 patients died of disease. So this is a thing. Now you could argue this is just a melanoma with a fusion, but I'm not sure. It may be a distinct entity. And I'm going to close the last 3 minutes that I have about this oddity, the nono-TFE3, cutaneous epithelial and spindle tumor. They have few cases reported, a recurrent translocation. I mean, this translocation is not unique to this tumor. It has been reported to XP11 translocation renal cell carcinomas. It has reported to visceral picomas, has been reported to microcystic reticular spannomas, but this seems to be something else. It has this spindle to ovoid cells. Some areas have perivascular accentuation. This was a case with nono-TFE3, but peculiarly, the case had SOX10 and melanocytic differentiation, but also had P63 expression, which is pretty unusual. So what do we know? It's something you have to have in your mind, because you see more cases about this. S100 SOX10 diffusely positive. MITF was not positive in 2 out of 3. P63 is positive in these cases. And I think I'm going to stop here. And I hope that was helpful, and thank you very much for your attention.
Dr. Linos, thank you so much. This was a absolutely brilliant talk, a complete overview with important clues for differential diagnosis. A lot of information to absorb, perhaps. I'm a little bit conscious with time. Not sure, Artie, whether we should move on to the next talk, or will we take any questions at the end or now?
Maybe 1 or 2 questions.
Okay. Does anyone have any pressing hot questions? There's a hand up. I think Somaya.
Somaya, you're muted.
We can't hear you, Somaya.
Salim, do you want to go ahead?
My question, that's amazing talk, thank you, is, I'm sure some of these cases are being signed out as melanomas, especially, when you don't have all the techniques available. What would be sort of key messages to alert us that we're not dealing with a melanoma? I know you've touched upon that in the talk, but just to really emphasize that again for us, please.
I think the most important thing, is morphologically, I mean, it can get you so far, but it can get you quite far, is the uniformity. If you see a tumor that looks quite uniform, despite the fact that stains like melanoma, and it looks malignant, it is malignant, and stains like melanoma, but it looks quite uniform, then I think you have to pause, and you can do a BRAF and NRAS immuno, that may be helpful, but you have to pause and see, am I dealing with a fusion positive tumor? You can do PRAME. If it's PRAME, it's positive, then okay, maybe melanoma. If it's negative, it's not going to help you. But I think despite all this molecular I gave you before getting there, to avoid the trap is the morphological uniformity. I think that is a clue that we use here. A lot. But of course, it's all about resources, right? I mean, I can do molecular here in a second. I don't think about it. If you don't have that capability, you can get so far. But if you have doubts, then then you have to send it somewhere else where they can do more, because it's important, because the fusion-driven tumors, more likely they're not going to respond to immunotherapy, right? Of course, there are exceptions, but they don't have a high TMB. So now they're not gonna go the immunotherapy. Most likely, you never know. They may give it anyway, but most likely it's not going to work. So that is my message from the good old H&E.
Thank you.
I don't know if Somaya is.
Yes, sorry guys, can you hear me now?
Yes.
Yeah, thank you, Dr. Linos, for the excellent lecture. I just wanted to ask, what sort of platform, genetic platform are you using for these cases?
Yes, we have Archer that covers 136 genes, but now we just moved to a whole RNA transcriptome. And then from DNA, we do the impact DNA, which is DNA sequencing covering about 500 genes and give you copy number aberrations as well. And then if I only want to look at copy number aberrations, which is not applicable for this particular talk, then we have SNP array. So impact and whole RNA transcriptome we use now.
Excellent, thank you so much. I think, some of the cases that, for example, for the TRIM11, we had very sort of morphologically classic cases, but because we are relying on a platform called the TrueSite Oncology 500, it doesn't have a TRIM11, so,
You can bring, actually we brought here because it's faster. You can, if you have cases, you can validate and do the FISH. It works very well.
Okay. Thank you. Thanks.
Any other? It keeps coming back to this correlation of morphology. How do we define things based on morphology or based on molecular? We had this question in the morning as well. I think MITF is gaining more respect, certainly for me.
Yeah, that's right. Yeah, I wasn't using it for years, and now, you're in this with these tumors, you have to use it.
And it's also interesting that there is the MITF pathway lesions, and then MITF is activated in clear cell sarcoma, in CRTC TRIM11. So it's not clear the lineage. This is a very fascinating zone. So thank you very much, Dr. Linos. I'm glad that we have recorded this talk. I think people will go back a few times. I don't know. Do you use the Heidelberg classifier? Is one quick question.
We use it for sarcomas.
Yeah. Okay. I think now we should move on to our next speaker. We are delighted to welcome Dr.